The use of vitamin C in sepsis is a very hot topic, and I will discuss that today. I don't have any conflict of interest in relation to this topic. Vitamin C levels fall in critical illness due to increased oxidative consumption, and septic shock patients have particularly low level of vitamin C. Humans are unique together with guinea pigs in not being able to synthesize vitamin C in their body. Recently, an observational study of before and after intervention presented data that a cocktail composed of vitamin C, hydrocortisone, and thiamine was able to dramatically decrease mortality after its introduction in a single center, and to also markedly decrease the use of vasopressor drugs. Accordingly, there has been a great deal of interest in this kind of intervention. Therefore, we conducted the vitamin study, which is a study in patients with septic shock. It is a study with 10 sites and 3 countries: Brazil, New Zealand, and Australia. This study was published in the Journal of the American Medical Association this year. It's an international open-label randomized controlled trial to compare the effect of the cocktail of vitamin C, hydrocortisone, and thiamine compared with hydrocortisone alone on time alive and free of vasopressor administration in patients with septic shock. The diagnosis of septic shock had to be present, and the intervention had to occur within at least 24 hours of the onset of septic shock, which was defined according to the sepsis consensus criteria. There were a variety of relevant exclusion criteria which were logical given the intervention at hand. Patients were randomized to a control group or to an intervention group, and the control group had hydrocortisone, 50 milligrams 4 times a day, and the intervention group had vitamin C, hydrocortisone, and thiamine, and the intervention was continued until the cessation of vasopressor administration or the discharge of the patient from ICU or 10 days of treatment having taken place. The primary outcome was time alive and free of vasopressors at day 7 after randomization. The patient had to be both alive and not receiving vasopressors for at least 4 hours. There were a variety of secondary outcomes: 28-day mortality, 90-day mortality, ICU and hospital mortality, and other clinically relevant outcomes. The sample size was calculated to have sufficient power to detect a 25-hour difference in the duration of time alive and vasopressor-free state. We calculated an initial sample size of 126 patients, and then we reassessed the sample size by looking at the standard deviation of the pool of all the patients. And we inflated the sample size for the non-parametric distribution and therefore went to 216 patients. We screened 786 patients and randomized the 216 as agreed. And most patients were excluded because they had diagnosis of septic shock for longer than 24 hours or death was considered imminent. The randomized to screen patient ratio is 1 to 3.6, which is typical of ICU studies. Patients were randomized with a consent withdrawal of 2 and 3 in each group. So the primary analysis was available in 105 and 102 patients in the 2 groups. The baseline characteristics of the study groups were well balanced, and the age was approximately 61 years, with most of the admissions coming from the emergency department. A few patients had received hydrocortisone for shock before randomization, and 2/3 were on mechanical ventilation at the time of randomization. The patients were mostly receiving norepinephrine, but 1 in 5 was also receiving vasopressin. Renal replacement therapy was applied to 10%. The WISA count was elevated, the lactate was elevated, the serum creatinine was elevated, and acute kidney injury was common, and the Apache score was high. The pulmonary and the gastrointestinal systems were the most common sites of infection. The intervention was appropriately administered, and the treatment duration was 3 days. and the time from eligibility to first dose was 12 hours. The primary outcome of time alive and free of vasopressor support up to day 7 was essentially the same in the intervention and the control group, with no significant difference in the median of all pair differences. We then conducted a sensitivity analysis with stratification and baseline imbalance corrections, and there was no difference between the two treatments. We also looked at the secondary outcomes such as 28-day mortality, 90-day mortality, ICU mortality, and we also found no difference. When we looked at the time to event with a Kaplan-Meier curves, and we looked at the hazard ratio for the time to cessation of vasopressor drugs, there was no difference between the two interventions. Finally, when we looked at cumulative vasopressor-free days, mechanical ventilation-free days, and renal replacement therapy-free days, we also found absolutely no difference. And the same was for ICU-free days and hospital length of stay. Post-hoc analysis focused on the timing and vasopressor-free hours. So we divided patients into those that had a late randomization and a mid-level randomization or early randomization to see if there were any differences between these four groups, and there were no differences. We looked at the timing of intervention and 90-day mortality to see if early intervention would be associated with more favorable outcome, and we found that in fact there was a trend towards worse outcome when the intervention was given in the first 5 hours after fulfillment of the septic shock criteria. So we were able to conclude that in patients with septic shock, treatment with a cocktail of intravenous vitamin C, hydrocortisone, thiamine, compared to hydrocortisone alone, did not affect the duration of time alive and free of vasopressor administration. This finding suggests that the use of intravenous vitamin C, hydrocortisone, and thiamine together does not have beneficial effects on the resolution of septic shock. Now, this trial was taken to potentially represent the end of vitamin C in sepsis, and as we were the protagonists of this trial, we felt it necessary that we should explore vitamin C further, and we considered the option of megadose vitamin C. The first thing that we did is to look at whether there was any evidence that high dose or megadose vitamin C was safe. We did a scoping review of all the literature that had been published on megadose vitamin C, and we were able to identify 74 studies with very high amounts of vitamin C being given up to 150 grams per day intravenously. We found there was no excess of adverse events, and in small randomized controlled trials of cancer patients in particular, there was no evidence of toxicity and only minor reports of hemolysis in patients with G6PD deficiency. So megadose vitamin C appeared safe. So we went to test it in a gram-negative bacteremic shock model in the sheep. And we randomized animals to either receive vehicle or megadose vitamin C for an equivalent of 3.5 grams per kilogram. As you can see in these slides, the administration of megadose vitamin C had a dramatic effect on the requirements of norepinephrine, which plummeted to 0 with megadose vitamin C, while remaining high and going further high in the vehicle-treated animals. When we looked at the heart rate, there was a significant decrease in heart rate, and was also a significant resolution of fever with the administration of megadose vitamin C. We then looked at the urinary output, and there was a dramatic increase in urinary output with megadose vitamin C. And in these animals, we were able to demonstrate that creatinine clearance was also dramatically improved with megadose vitamin C. These animals were heavily instrumented, and we were able to measure renal medullary perfusion and renal medullary oxygenation, and we were able to demonstrate that high-dose vitamin C was also able to dramatically improve medullary oxygenation and return that to a pre-intervention level. So, high dose vitamin C does not appear to have a clinically important effect in human sepsis and septic shock. However, in an experimental model, megadose vitamin C now appears to potentially have a significant effect in gram-negative bacteremia with dramatic beneficial physiological effects. Given these observations, we feel it necessary to abandon high-dose vitamin C in sepsis and to begin a program to assess the role of megadose vitamin C in human sepsis. We believe the story of vitamin C in sepsis is not yet finished.